Hi, Don here. Welcome to Podiatry Practice Mastery, where we're going to go over the things that help get your practice to the $1 million mark and beyond. I want to share kind of one of the challenges and kind of a potential solution for something in our office. What we're finding is as we do more and more shockwave therapy, it's taking up more and more spaces in the office, and sometimes patients are used to seeing us and they maybe don't want to see another provider. I'm kind of preparing myself to say, hey, if I have, let's say, 15 or 20 patients a week that I'm doing shockwave on, is there a way that a portion of those would see someone else? And I want to take an analogy that I heard recently for like a restaurant. So some restaurants, let's say, they are busy on the weekend, on Saturday and Sunday, Friday, Saturday, Sunday, but there's less time during the week. And so one option is to charge 20% more Friday, Saturday, Sunday, but it's all how you frame it. Like charging 20% more to use it on the weekends isn't a good idea, but you could do it just the opposite. What you could do is you could charge 20% less during the week, and that way people think, well, if I go on the weekend I'm going to pay normal price, but I'll get it 20% less if I do it on during the weekday. So a way that we could institute that in our office would be charging, let's say, 20% less for the shockwave by having a certain trained assistant do it for us. That way, my thoughts are I could do the first and the sixth, but then I could have the other medical assistant or other person that would be doing it. They would charge a little bit less. You would just pay them whatever their hourly rate is, and then they could do the shockwave, or they could do other things for us in the office. So it's a way of getting the patients would maybe want to see someone else. Like you could say, oh, you could see Dr. Pelto for these, or you could see this other person, and if they do that, you could get a discount for doing that, because it's not up taking my time. Okay, so what's happening today? One thing I always like to say, kind of things that embarrass me as well. So I got caught not wearing gloves. So let me explain what this meant. When I make my videos for my YouTube shorts, I usually do the whole treatment process, and then I will get out my phone and I'll record a YouTube short for that patient encounter. If you want to see them, you can go to my YouTube, which is Dr. Pelto at YouTube, or you can see it on LinkedIn or other places where I do these shorts. But usually I do it with a glove off, only because I've already done all the treatments and I'm just kind of pointing out things. But someone poked fun of me on LinkedIn. They called me out on it, and they said, hey doc, you should be wearing gloves. So a little bit embarrassing moment, but I just want to say I'm going to start now. When I do videos, I'll start wearing gloves for that. Okay, so let's do my recording. This is a recording for a Tuesday in the office, and I'll kind of explain the rationale between some of these patients. So the first patient was a 58-year-old female. She had an anterior calcaneal fracture that was noticed, and she was kind of overweight and wasn't really a good surgical candidate, and really there wasn't a great surgery for that. I did 6 sessions of shockwave, and now she's about 80 to 85% better. I got x-rays now comparing it to like 6 weeks, or actually more like 3 months ago, and there's healing in crossing over that fracture site. So I did that. I didn't do another session of shockwave. This was a follow-up. She also asked for nails and callus care, so I did that. I'm going to see her back in 3 months, get another x-ray at that time, but this is really just the shockwave follow-up. So she was a success, and she's feeling so much better. She's out of her cam boot. Next was a 56-year-old male. He's an orthotic 6-week follow-up, and he also had a question about one of his nails, so I debrided that nail. So it would be an office visit. His orthotics are feeling good. No follow-up, but I did debride that thick nail. So I think a lot of times if you see a patient, for example, with a callus or with a thick nail, you're not going to see them back for a long time, or you may be not seeing them back. But I think just adding that on can do a bump up in your office charge. I'm always an advocate of what you can do that provides value to the patient, but then will also increase the per visit value for that specific visit for the patient. So just adding simple things like adding a callus. And maybe they even know it's not covered, so you'll charge for that. Or adding a foot cream, or adding something else like that, just can increase that amount for the visit. So it would be something that's a typical normal office visit. It can increase that amount, and that's one of I think the easiest low-hanging fruit to get to the $1 million mark. Next patient was an 83-year-old female. She had bilateral hallux rigidus. We did x-rays bilaterally. We talked about that, so we did the office visit for that, level 3 visit, and then we did nail care. She also wanted nail care, and so she's going to be seen back in 3 months by my nail technician. So I also introduced my nail technician, saying that she would be the one that would be doing the care. Next patient was a 45-year-old female. She had bilateral insertional Achilles tendonitis. I did bilateral shockwave for her, combo, which is radial and then non-radial, and that was number 2 out of 6. Now I want to explain about this patient. So she originally, last session, I only did one side, and both sides were bothering her, and this is kind of an ethical and financial dilemma. So I feel bad for this patient. I did bilateral ultrasounds today for her, and it showed that there was a fusion and swelling at the insertion. She has a spur. On the good side, there was kind of a normal thickness, but on the bad side, she's had 10 jet on that before, and it's just really thick. And I couldn't, in good conscience, only do one side because that's all she could afford. So what I told her is, I'll do both sides. I'll kind of chalk it up as a pro bono. And she works at like a convenient urgent care as a rad tech. And so I said, you just try to refer more patients. So I think that's going to create a lot of goodwill. Some patients that can't afford the bilateral, a lot of times I'll add it in because it doesn't take me much longer, and I just feel better about doing that. And I think from that goodwill, many other patients will be referred to the office. Next patient was a 79-year-old man. He had sciatica, and he came in from his primary care. I looked at his x-rays. He has some foot manifestations, and he's already going to PT. He's already on gabapentin. I talked to him about doing an orthotic, and that's something that he wanted to do, so we did orthotics for him. Next patient was a fracture of the second metatarsal, and she also had a bunion. So for her, she had a stress fracture in that area from doing a lot of walking while she was on vacation. I gave her a cam boot and an even up. So once again, as we're talking about increasing the per visit value, anytime you can add something. So one thing we always add when patients get a cam boot is I say you're going to get an even up. So even up is something that evens up the height so it doesn't throw their hips off. Another thing that patients get, so when they're doing matrixectomy, they're always getting the post-op kit. So these are things that you're adding on to things that you're already doing. I think this is obvious, but I'm just kind of being clear to kind of instruct on how to get to the $1 million mark. Next patient was a 75-year-old female, hallux fracture follow-up, and x-ray only. So if I'm talking about least valuable patient, this is probably the least valuable patient of the day. She had a fracture. It's doing better. I only got the x-ray. I didn't get any office visit. She didn't really have any other issues. I don't know any other way except just reducing the amount of follow-ups for these that you can reduce the low-value patients. I guess one option would be, I'm just thinking about it out loud, the same way that I see my matrix follow-ups in a 10-minute slot in 3 weeks. If it's going to be a simple fracture, I could do my fracture follow-ups with x-rays in my 10-minute slots. So kind of reserving those 10-minute slots in my schedule to accommodate the things that wouldn't relegate to a higher level visit and would be just only an x-ray. So that would be something that I could also do in the future. So I'm starting to develop this list of like 10-minute appointments that are going to be quick and usually easy. So I could add this to this. Like usually it's a matrix follow-up. Paranickies I'm not even seeing back. Maybe even like a simple orthotic follow-up. Putting these in these 10-minute slots, I think that might be a good reason to do those. Next patient was a 60-year-old female that had bilateral ankle replacements, and this was done by another person in Boston, and she was here to see me to get the orthotics afterwards. So she currently has orthotics. I did a new pair of orthotics for her. We scanned her, and then she will be seen for follow-up at the 6-week follow-up. Now, even I'm just thinking out loud here, so even some of these patients that I always see for 6-week follow-up for orthotics, in this specific case, if she's been used to them and they're fitting fine, she might not need that 6-week follow-up. The next patient was an 84-year-old man. He was here for after his Lamisil booster. 9 out of the 10 toes got better. I think that's considered success. And he has one toe that has something. I could potentially switch him to something else like a diflucan or a Sporanox, but in his specific case, at his age, I'm just going to call good enough alone, and I'm going to leave it. So just the office visit for that one. Next patient was a 73-year-old female. They had calluses. I trimmed those calluses, and it was just like a self-pay. I don't know how she got into my non-routine day, but I think it's because she was just saying she had painful feet, maybe a wart. That's what she called it. But when I looked, it was a little over a year she was here for those calluses. So I did counseling for calluses, so that was a level 2 office visit. I don't do many of those level 2s, but level 2 office visit counseled about Callus's orthotics, and then I did the Calluses, which were $75 for that patient. Next was an 85-year-old with a matrix follow-up. That was a quick one. Once again, these are my 10-minute slots that I'm using. Next was a kind of an interesting patient. This was a 43-year-old female that likes to do a lot of running, and she had an MRI done in a tibialis anterior tear at the insertion. And we talked about different treatment options. She's already been in a cam boot for about 2 months, and it's still not better. So we set up number 1 out of 6 of her shockwave. So she did shockwave today, and she also has a wart on the right foot. So the tibant tear is on the left, and for the wart, we did cantharidin on the right side. So we were able to get the cantharidin bill and as well the follow-up MRI and the shockwave for her. Next patient was a 65-year-old man. He had a recurrent ulcer on the tip of the hallux due to a previous first MPJ fusion where it caused a kind of a cocked down hallux. I'm going to see him back in 3 weeks, and I debrided it. So I got the office visit, the debridement, and the follow-up. And I have a short referral patient. So if he's not better in a few weeks, I'm going to send him to the wound care center. I don't do a ton of wounds, as you can tell by these little discussions we have here. Next patient was Swift number 6. I usually do 4 Swift, but today he needed another one, so he was number 6, and I'm going to see him for a 1-month follow-up. I did cantharidin as well. So one other thing about Swift, usually I do Swifts, and if I add on cantharidin, I'm not billing for the cantharidin and the Swift. I just sometimes feel like it's double dipping, and cantharidin doesn't really take that much. Yes, you have the liquid you put on there and the bandages, but in his case, he's already on number 6, so I will just do the cantharidin without charging it. I guess one other option is you could do the Swift without charging it, but I tend to do the cantharidin without charging it. One other option I've kind of thought about, if you do use Swift, I know they have a benefit, I guess they say, like if you do a video about your Swift, they will credit you, I think, a box of Swift tips. So I was just thinking about this out loud. So potentially if you do videos on some of the patients that maybe can't afford Swift, you could theoretically not charge them because they would get the box that comes with the Swift. It's one of the added benefits of making video or doing social media stuff for them, like sending them the video that you did, and then doing it kind of pro bono for some of these patients that maybe can't afford it. I thought that's kind of a neat idea, and just say, hey, if you do this video, we can do it for free because they're going to give me a free box, and a box will have so many tips in there. That was just an idea I had today. And then the final follow-up was the 65-year-old for a right fifth. I'm trying to read my handwriting. 5th Met resection. I think what I did for this one here is I did cantharidin on this one, so like a 5th Met cantharidin for this patient. Okay, that was the day. Once again, I have a practice, like $1 million practice blueprint on my website, Podiatry Practice Mastery. If you found this beneficial, I kind of do a deep dive into all these topics that I'm talking about here. You might find it beneficial. I'd love to share that with you. And also, if you want to see my daily treatment tracker, this is what I use every day to kind of track what I do, and I think it keeps it front of mind. So even if you're not going to record your own podcast, I think recording it and kind of keeping the most valuable patient out there is a good thing to do. Okay, until tomorrow, thanks guys.